Fantastic.
So, thank you, Sam. Thank you.
Well, thank you very much indeed for inviting us, Cheryl, and thank you very much, colleagues for the from the NNA for joining us today. NNA's, I don't know if you feel this, but the system values the Neonatal Nursing Association very highly. We're very aware that neonatal care is fundamentally done by nurses, doctors, AHPs. Others have some role to play, but the neonatal nurses are really where it's all at. And the system understands that. I don't really quite consider myself part of the system, but we know that the representative bodies need the voice of neonatal nurses, and the NNA is how that comes. So it's great to be talking to grassroots members thereof. I'm going to try and share some slides. Always exciting to do things in Zoom, and hopefully you can see that now. Can you see some slides, people? Participants can now see your screen. That's very exciting. I'm Sam Oddie. I'm a neonatologist in Bradford in West Yorkshire, but I'm clinical lead for the National Neonatal Audit Programme, and I'm slightly scared trying to get it up. So sorry, you're over here. I'm bringing you all back onto my computer because I like to talk to actual people as much as I can. I'm apparently going to give a talk about what, when, how, and why. And then there's a few items, but we hope that you might want to ask questions and maybe turn this into a bit of a conversation. So as Cheryl said, the chat is there. You can use that, and Rachel might pick out some stuff from the chat, or she might answer them in the chat depending on how it feels. But having a bit of to and fro is really fine with me. So I'm going to try and cover what we are, who's in control, and give you a feel for how it works and what we've shown. And I hope that you'll have a sense of whether we make any difference. And perhaps a bit of an idea about what we're going to be doing differently in the future over time. And I'm very conscious that some of our measures depend completely on neonatal nurses' data entry. In fact, pretty most of them depend on that. So hopefully we'll be giving both due respect, but some level of understanding of how to improve the data quality, because there's always data quality to improve. The purpose of what we do is supposed to be both benchmarking, so about delivering consistent high quality care according to professionally agreed guidelines and standards, but importantly about facilitating improving the quality of the care. So, and that's substantially about identifying variation, so differences between neonatal units in their care process and in their outcomes, but also trends over time. So I think the facilitating QI is a really big part of it. There is an element to which people use national audits like NNAP for a data assurance, for the quality assurance of services. So our service must be okay because our antenatal steroid rate is X. I think what NNAP doesn't really do, but you might disagree, it's not really about showing the parents that we're doing an okay job. I don't think the parents really look at most NNAP stuff very much. They occasionally look me up, I have found, but mostly I think parents don't check out the quality of the service that their baby's in. That's my impression. So who runs the audit? Well, the Royal College of Paediatrics and Child Health. So if you like, my professional body runs the audit, and it's commissioned on behalf of the English, Welsh, and Scottish governments by this body called HQIP. There are commissioners, but the money comes from NHSE and the Welsh and Scottish governments. But who really runs the audit? Rachel really runs the audit, is the answer to that question. So Rachel runs the audit, ably assisted by Lucy, who's also on the call. And then there are two men. So Humphrey, our fantastic data analyst, and some strange bearded bloke. I think we're quite proud of NNAP, but we have to be honest. And one of the reasons that NNAP works as well as it does is because of the historical accident of us, or kind of accident of us all being users of Badger. And so we have had this high quality data tool at our disposal, and that's been around for quite a while and has been really transformative. And it's one of the reasons that compared to maternity, neonatal data is way better, and the output's therefore way more meaningful. So in the past, it's a very old slide. There was this kind of issue about whether we were how we related to these other bodies. So we're not the same as CleverMed, but really this isn't. Whoa, oh, that was exciting. So this isn't the conversation now. The conversation is really to understand how we use data that you put in Badger, because we don't have a relationship with NDAO, and to some extent we are, well, to a significant extent, we're really very separate to CleverMed. So if something needs changing in Badger, we've sometimes got a role to play in that, but most of the changes that are made to Badger are not made by us. So I'm sure every bed space in the country has a computer next to it, and you can see in the infographic here, I hope, that there's people typing information about their patients, perhaps in the daily data. That data gets transferred in close to real time. I like to think of it flowing down the wires down to London to RCPCH, and the cleaned data produces in the bottom left-hand corner here, allows us to produce an annual report. And in principle, that annual report is used by units to inform their quality improvement. In fact, we generate quarterly data, so-called, I'm going to have to turn my camera off because something very strange is happening on my screen. Apologies. I could just put it down. Apologies, it was just my screen was flashing at me. In practice, we produce quarterly outputs at the moment, and that's rapidly going to be changing, and I'll try and cover that today. So we send both quarterly outputs. So your antenatal steroid rate is looking like this, the national average is this, and here's a way of improving the completeness or quality of your data, and that's how we're working at the moment, but that's very soon to change, as I say. So at the moment we issue an annual report. We're just trying to prepare that for the 2022 data. We send this quarterly data feedback to units, and we also send that to the ODNs in England and the equivalents in Scotland and Wales. We do identify outliers, so units with exceptionally good or exceptionally lower than average performance on certain measures. We produce a version of the report aimed at parents and carers. I'm told that we have quite a lot of brand recognition for the unit level posters. So we produce posters that I would like to think are displayed in every neonatal unit in the country. They're certainly displayed in mine. There's a poster A and poster B, and I'm thinking I'm going to come back to those. Our report contains these so-called at-a-glance infographics. So in principle, this is supposed to summarize the whole report on 2 pages. They're very pretty. I'm very interested to know whether anyone actually finds these useful, but they make quite a nice slide. So I'm not going to dwell on these because I'm going to show a little bit of breakdown. We break the report down and the things that we measure down into outcomes of neonatal care, so mortality. I'm going to talk about some of these separately, and other outcomes. We talk about optimal perinatal care. So people on this call may be familiar with NEOSIP, the Maternity and Neonatal Safety Improvement Program, underpinned by something called Saving Babies' Lives Care Bundle, which was just published, a new iteration was published a few days ago. But these are the 5 things that in 2021, because I can only show you the 2021 data at the moment, we were measuring. Now we're now measuring early breast milk as well. So of those 7 interventions in NEOSIP, we're measuring the activity around 7, and I'm going to show you the data for some of these in a moment. So in fact, straight into it. And here's a striking example of how things vary between units in the country. So this is about deferred cord clamping, a practice which has been shown to make a huge difference to mortality in preterm babies. Along the horizontal axis of this figure, you've got the neonatal units in order of how widely they practice deferred cord clamping in babies of less than, in this case, 32 weeks. And on the vertical axis, you've got the proportion of babies in each neonatal unit who get deferred cord clamping. The colors of the colors of the dots represent, each dot represents a color, and they form a so-called caterpillar, which is why it's called a caterpillar plot. And the red ones, or red or pink, that's a NICU. The blue ones are local neonatal units, and the gray ones with their associated error bars are special care units. And you can see there's enormous variation in the proportion of babies that get deferred cord clamping. We've got intensive care unit up here that is doing deferred cord clamping in about 80% of their babies. And in 2021, there was a neonatal intensive care unit that described itself as doing deferred cord clamping in less than 5% of its babies. So huge variation. And that variation is seen throughout, but this is a very striking example, are measures of both care process, but also outcome. This is another way of showing the same thing, same sort of plot. This is the ODNs. At this point, Scotland was outside the audit, so apologies for any Scottish colleagues on the call. And you can see that there's a neonatal network, the Southwest ODN. Southwest is really good at loads of stuff that do deferred cord clamping to a very high proportion of their patients. And the other neonatal networks vary. This is, we think, helpful in terms of driving improvement. We hope it is. So I said I was going to talk about perinatal stabilization. Keeping babies warm, that's a thing that neonatal nurses and doctors are highly invested in. And over time, in this figure from 2015 to 2021, the light blue is the proportion of babies who are on their first temperature admitted to the neonatal unit, that is between 36.5 and 37.5 inclusive. And you can see that we've got consistently better over the years at that. And the yellow, orange, that yellowy orange bit is the babies who are too warm, and that hasn't really got bigger. So we're excited by that, and we think this is probably a best in the world. Well, we think this is a best in the world figure. And then there are some cold babies, and the proportion of cold babies has gone down by about a half. It's about half what it was. So we should be pleased about that. And we can look, and we find our colleagues in the Thames Valley are particularly good at this. And neonatal networks vary in terms of how good they are at keeping their babies warm, although they're quite closely clustered around the sort of 70% figure that you see in this figure. Another element of keeping babies right at birth is delivering them in the right place. We had a fairly basic interpretation of the delivering the little babies in the right place guidance. This is a year-by-year plot showing a bit of improvement in getting the little babies delivered in centers of the NICU, but not much improvement, to be honest. And here's a very complicated picture that I'm very fond of, so I'm going to try and talk to this. So this is another caterpillar plot showing variation in the black dots of the neonatal networks, how good they are at delivering their babies in the centers with a NICU, the little babies in the center with a NICU. And you can see that there's quite a lot of variation in those black dots. Some networks have got more of an issue than others. It also shows some light gray and some dark gray dots. And this shows, and it's most obvious actually for East Midlands, who in the 2019 data had a really significant problem and made a really big change. So I think this slide illustrates that for networks who've got a problem and recognize it in the data, they can address and change their clinical flow and make quite a big difference to this. And so East Midlands is a network that made a big difference over those three. And in fact, there's improvements in most. This network improved and then got a little bit worse again in 2021 data. The 2022 data, they'll know what their own data is, but they won't know how everyone's getting on across the piece. So we think this is evidence that that stuff can be changed, and there's loads more of that in the data. So that's a group of measures that we talk about perinatal stabilization. Parental partnership in care. We've got a bunch of measures. I'm going to show you some of those and get a bit of a feel for that. And I'm really happy to take questions about these if they don't make sense. So I'm going to go through these one by one. So breast milk feeding, something neonatal nurses and doctors very invested in. This graph shows from 2013 to 2021 along the horizontal axis, the proportion of babies, in this case of less than 34 weeks from memory, who went home receiving any breast milk. And you can see that there's absolutely no change. There's no real change. There's a little bit up and down, but in general, we've not been very successful at improving the proportion of immature babies who get any breast milk at discharge. This isn't even breastfeeding. This is breast milk feeding. So we think this is quite disappointing. If we can look in the same measure in the bottom caterpillar plot here and show that the neonatal networks are not all the same, which won't be a surprise to anybody who's lived in different parts of the country. As my mother would have said, in the frozen north, she wouldn't really have said that, but we like to say she would. In general, in the north and the west of the country, rates of take-home breast milk feeding are worse, and in the south, where I was born, in general, people are better at taking the baby's own breast milk feeding, or we're better at supporting it. So we've also got a measure of the proportion of babies who receive at least some breast milk on their 14th day, because we felt that it wasn't really okay just to concentrate on breast milk feeding at discharge. There's much less separation in this plot. I hope that's reasonably obvious between neonatal networks. So we're generally more successful, and a much higher proportion overall. It's not around 60%, it's around 80% of babies are getting at least some breast milk on day 14. So we should be encouraged by that as a professional community. We thought that even this wasn't perhaps as helpful as it might have been, and we've produced, I'll skip over that slide. We've produced some graphs of which this is not a real patient. This is designed to describe the success in administering breast milk to babies over time. And this is taking all babies of less than 32 weeks, I think. This is babies of less than 32 weeks. So we call these the breast milk plots, and this is just designed to give you a little bit of an idea what good might look like. So along the horizontal axis is days of age, and on the vertical axis we've got the proportion of babies who are receiving milk according to different milks, different colors. So black is nil by mouth, gray is formula. It's likely that there will always be a proportion of babies who don't receive any breast milk for whatever reason. But we thought that the ideal was the vast majority of babies would receive at least some breast milk, even out to very late. And this black line divides the patients who've been discharged. So it describes their milk feeding on the last day that they were in. And we thought that the ideal was they would all be receiving at least some breast milk on the last day in the neonatal unit. And then there'd be some babies who were fed formula. Of course, the reality is really very different. These are done by Neonatal Network, but you can find these for your own neonatal unit on NNAP online. Just Google NNAP online. So you can see where my son was born, where my daughter was born in the Yorkshire and Humber. There's quite a lot of formula feeding of immature babies, really quite a lot, and really quite a lot of formula feeding of discharged preterm babies. And perhaps a smaller bit of green here. Whereas where I was born in South London, it's predominantly green. There's a relatively smaller number of babies who are fed. And so our idea was, and we haven't really evaluated these, but our idea was that these would be helpful to you in terms of interpreting the breast milk use and where the problem was, if there was a problem in your neonatal unit. And so they plotted, these are available at unit level, and we hope that they're helpful. So I said I talk about parental partnership. We think breast milk is definitely a parental partnership activity. Doctors might think parental partnership is just about talking to the patients within 24 hours of the baby arriving on the neonatal unit. So not a high standard, I think you'll agree. And over time, we've got a bit better at that from 2013 to 2021. The pink is missing data, which there's relatively little now. And in general, we're quite good at hitting that quite low bar, clearing that quite low bar. But in more than 19 cases out of 20, we managed to talk to the family within 24 hours of the baby being admitted. And there's a definition for who counts. It's a senior doctor or an ANNP operating as operating in a tier 2 role. So we've stopped identifying units as outliers for this, rightly or wrongly. And we take comment about that. We're also taking the lead from our parent representatives and from our colleagues at Bliss. We have for some years now had a measure of parental attendance on parental involvement in consultant ward rounds. And if we say that the standard is that the parent should attend only one or more ward rounds during their baby's stay, then quite a lot of parents attend a consultant ward round. But probably that's not the right measure, because so what we're actually talking about is describing the, I can't remember whether there's a good slide of that. No, there isn't. The proportion of consultant ward rounds that were attended, where the parent was involved in them. And so our measure has evolved a little bit. And there's a real challenge there. So you can look up your own units data on NNAP online, but there's a real challenge in terms of delivering our services in a way that allows a ward round to plan care for babies that is genuinely parent involving, and then recording the data of that. And that principally depends on nursing colleagues entering the data in the daily data. And there's a definition of what counts as a ward round. It's one led by a consultant. The daily data form is hopefully unambiguous, but if you think it's ambiguous, then you should definitely let us know about that. So we're keen on this measure of parental partnership. I have to say some doctors are really not. And I wanted to say something about outcomes of neonatal care, because it's no good having good results just for care processes. It seems to me that it's really all about trying to improve the outcomes. And so on this summary slide, which is lifted from the report, there are some outcomes listed, but we've got more now. And I'm going to take you through some of those because I think they're quite, I think they're quite shocking, to be honest. So clearly, if we look after vulnerable babies, some of them will not survive, and the proportion of babies less than 32 weeks who don't survive is about 6%. We exclude from that reporting the 22 and 23 weekers, not because we think they don't matter, but because we know that they're not admitted in the same proportions around the country, and that's certainly true for 22 weekers, and it certainly was the case that was true for 23 weekers when we started doing this reporting. Here is a caterpillar plot for mortality. So on the horizontal axis of this particular plot, we've got the different neonatal networks, and on the vertical axis, we've got the proportion of babies who die, and this is before 44 weeks. You can see that the average is about 6%, 6.4%. But it's striking that there are some networks here whose mortality is nearer 8%, and there are some networks here whose mortality is nearer 4%. So naturally, when we showed this data, the first time we showed this data, people's response was, well, our babies are different. And so we took care to conduct, and we've done this in a number of different ways, well, in evolving ways. We do an analysis which in effect takes account of the case mix. So we ask the question, how would the babies in each network have got on if they'd be looked after elsewhere, by taking the baseline characteristics of the babies in one network and finding matches for them, in effect, in the rest of the data set, and seeing how similar babies got on elsewhere. And that allows us to describe a so-called treatment effect. So, and you'll see that the neonatal, those of you who, I can see some people moving towards their phones, trying to see more closely, you'll see that you may be able to see that the neonatal networks are in pretty much the same order. Now, the order is not really important, but what does matter is where the position of the dot and how big the error bar is. We can describe, though, a treatment effect for mortality, which seems to show, I'm going to show you another slide in a moment, that the babies in parts of London, for example, have a way lower chance, about a 2% overall lower chance of dying than in other parts of the country. And this difference in treatment effect looks to be statistically significant. So that's pretty important. It's not the first time we found that. We found this repeatedly, and in general, it's the same sort of networks that feature. You can ask the same question, not for babies of less than 32 weeks, but for babies of less than 28 weeks. So there's 24 to 27 weeks inclusive, just for clarity. And there, of course, the overall mortality is going to be higher, so it's about 15%. And you see the same effect, the same sort of shape of caterpillar, and more or less the same order of neonatal networks, which is kind of what you'd expect. When you look at the treatment effect, you get the same sort of thing. So it does look as though being cared for in some neonatal networks, it is definitely associated with increased mortality. And there is a little bit of evidence that might be causal. It's not explained by the gestation mix of the babies, the birth weight mix of the babies, the ethnicity of the babies, the socioeconomic status of the babies, why they're born, those kinds of things. So you may have seen these boxes on the slides. So we are asked to endlessly simplify these very complicated things into key findings. There's a twofold variation in mortality, and then what are you supposed to do about it? What should units and neonatal networks do about these variations? Well, our recommendations group thought last year that taking a quality improvement approach to evidence-based strategies around antenatal steroids, deferred cord clamping, thermoregulation, treatment of respiratory distress syndrome, those were things that people could apply evidence-based practices. And in fact, I hope to show you that they actually, I can't. They don't. So I've already shown you for deferred cord clamping, it's the case that some units do that a lot more than others. And the second recommendation that we made was that neonatal units, I think in this case we said, should learn from externally supported mortality reviews. So not just have a look over their own deaths, but actually think carefully about why babies died in concert with somebody else. And that's a hard thing to make work well, I think. So I touched on mortality for babies of less than of 22 and 23 weeks. And this is the admissions for 23 weeks are pretty static. But this is the number of admissions for those 22 weeks gestation for 2016 through to 2021. And the 2018 data is suppressed because there's a too small a number for us to be able to show that. But I think you can see that there's a huge change in the number of 22 weekers admitted following the BAPM guidance, an enormous change, but the proportion of babies surviving is about the same, under a third. Of course, because there's so many more admitted, even if the proportion of survivors is the same, there'll be more actual survivors, at least to 44 weeks. And that's what we observe. It wouldn't be wild speculation to think the same thing had gone on in 2022. This is pretty important, I think. it's actually a lower survival figure than the BAPM document would suggest. And I think that's also important. And this for those of us who work in NICUs, this is quite topical. So I said I'd talk about other outcomes, and I've got I think only one other outcome to show you. So bronchopulmonary dysplasia, a really common outcome. So as you can see on the slide, more than a third of babies, well, about a third of babies get BPD. This is babies who are less than 32 weeks. 1 in 3 get BPD, but of course some of them die as well. So the reason we show these together is because babies who die early on, of course, can't survive to meet the definition for BPD, which is oxygen or breathing support at 36 weeks. So you can see that there's a wide variation in the proportion of babies who get BPD. The units in pink in this plot are the NICUs, neonatal intensive care units, and it's pretty clear, isn't it, that the babies in NICUs have got higher rates of BPD, which is probably because they're looking after, this would be the assumption, they're looking after harder babies. That said, between NICUs, they vary quite a lot, don't they? So there's an NICU with a BPD rate of apparently 60% of babies less than 32 weeks, whereas there's an NICU with a BPD rate of under 40%. But this clearly begs the question about well, are the case mix? What can you do about understanding case mix? I've inserted the slide, and here and that's why I've done it. And this illustrates that quite nicely. So babies at 22 weeks, they've all got BPD, 100% of them. 100% of survivors are dependent on breathing support or oxygen at 36 weeks. So that's pretty straightforward. Very high proportion of 23 weekers have BPD, and so on down through gestations, whereas at 31 weeks, it's about 10%. So understanding the gestation mix that's admitted to your neonatal network or your neonatal unit is very important. And we can do that by using the same methodology that I talked about, this so-called balancing analysis, taking the raw rates. This is the plot I've already showed you. And this mixes up the units quite a lot. But it's still the case that neonatal intensive care units have slightly higher rates of BPD. And that's probably because our case mix adjustment methodology isn't as good as we would like it to be. But we think that being looked after in a unit that gives you a 10% lower chance of having BPD, or a 10 or 15% higher chance of having BPD, we think those differences probably matter, and should be of concern to neonatal units that have high rates of BPD and high level treatment effect. And this data is available for your unit now on NNAP online. So I see that time is rolling on, but we're hoping to get any questions. Rachel, I'm guessing there aren't any questions to date?
No, I've answered a few, but nothing that warranted me interrupting you that I haven't been able to answer, Sam. But I'll keep an eye on, and I will interrupt if.
Do feel free, guys, to put questions in. That's absolutely fine. I have a tendency to talk too fast and skim over things, for example. So it's really okay, and we're relatively generous for time.
In fact, Sam, while you're on a pause, there's one that's come in. We might need to come back to it, but I'll read it out and see if you can answer it. Are there any mechanisms through which to differentiate between singletons and multiples in the data collection process and filtering into the analysis?
So that's a great question. At a simple level, networks certainly should expect to have the same, there should be the same number of twins in, say, Wales or West Midlands as, I don't know, say, London. And so you wouldn't really expect there to be much difference, but our, I keep calling it case mix adjustment because broadly that's what it is. It's a slightly different statistical methodology, but it does take multiplicity into account. So yes, when you enter the data, or when you or your doctors enter the data about babies and you say whether there are multiple or not, that's very important to us, and it's something that we take very seriously. Absolutely. In fact, yeah, and there probably are some units that admit significantly more multiples. There may be some NICUs that have more fetal medicine associated with them. We have a colleague in Scotland who often reminds us of the particular nature of their throughput. So I'll keep going. This is a final kind of screenshot from the report. One of the things that we do in NNAP is measure some care processes. And for the 2022 data, which we're just in the process of putting together a report about, we've got another care process. So we're looking at the proportion of babies who only under 32 weeks who only get managed with CPAP, because that's what NICE says you should do. That's showing some interesting results, I can tell you. But let's concentrate on the care processes that you see on the screen. I'm going to show you some data for some of these. In fact, I'm only going to show you, it turns out I'm only going to show you nurse staffing, because I knew that you'd be interested in nurse staffing, because hopefully many of you are nurses. So this is pretty worrying from my perspective. Some of you who've been around for a while will be aware that we had a bunch of measures of nurse staffing developed with NNA colleagues. And as due to, we became less confident that the QIS measure was appropriate, it was fit for purpose for comparing one trust to another. So we've got rid of that. And we now have a single measure of nurse staffing, which is a proportion of nursing shifts. And we in the data entry, we make the assumption that there's 2 shifts a day that have the sufficient nurses on them to meet the standard. Now, we don't ask people to do that maths from their unit, not because we don't trust you to do the maths, but because we know that people might do the maths slightly differently in different places. So we ask how many nurses there are. And of course, in Badger, we already know how many babies they are and what sort of babies they are. So we can make that calculation. And you can see for the 4 years displayed in front of you, that there was a bit of improvement from 64% to 78% in 2020, the pandemic year, but they dropped back off again. And this is way lower than we would all like it to be. This is 2021, the black dots compared to 2020, the light gray dots, and nearly everywhere was worse in 2021 than in 2020. Now, my personal hypothesis for 2020 being such a good year is that there was some redeployment to neonatal units from other bits of the hospital. But where we should be really concerned about the fact that we're nowhere near 100%. And we think that's really important for senior nurses, nursing managers, but all of us to plan the way neonatal units staff their shifts. I'm going to show you. So one of the pushbacks we get, to be honest, particularly from doctors, is that this is impossible to achieve. So this is a plot showing the different colored dots. So pink dots for NICUs, blue dots for local neonatal units, and gray dots for special care units. And the NICU doctors will always say NICUs have it tough and special care units have it easy. Now, special care units, because they need less nurses, are more likely to end up looking better staffed. And they always need to have some resilience, because if you only expect to have 4 patients and then you get a 5th one, you've obviously got to be able to look after that patient. So there's a structural reason why that's the case. What I would want to draw your attention to, whether or not you work in an ICU, is that there are ICUs that are of moderate size, like this one here, that have appalling staffing. Just over 20% of the shifts staffed according to the guidelines. And then there are NICUs of exactly the same sort of size that have really, well, better than average staffing, still nowhere near good enough. And that's true right across the spread. So it's not the case that big units have got an impossible problem, although the measure does slightly discriminate against bigger units. You can see that there's great variation, and that's true amongst the blue dots too. So we think there's stuff that can be done about that. We don't want to beat up on individual nurses for not doing that. That's around mostly about the hospitals, isn't it? We did think that this data was not that clear. And so for that reason, we've developed these plots, and this is all the hospitals in my ODN for the 2021 data. And what we hoped is that by smoothing out the occasional day, we would help the network and the hospitals to identify that there are particular times of the year. And in our network, it certainly was the case that in that year, that in the late summer and early autumn, lots of the hospitals were experiencing lots of times where there was the orange showing the staffing shortfalls. You can see that that's fairly obvious, and that was a time. It's not obvious on this plot, or it won't be obvious to you on this plot. It is obvious on the plot if you look carefully at it, that the vertical axes of the graphs adjust for the different size of the neonatal unit. So there's a neonatal unit here, for example, that has up to 16, 20 staff, and then there's a neonatal unit that only has up to 4 staff. So, but we hope this is helpful. We haven't really had a chance to evaluate this, but we hope that this might inform planning. A very small neonatal unit, as I touched on earlier, for example, Scarborough, needs to have some resilience in its nurse staffing. So in effect, it needs to be a little bit overstaffed in case a 25-weeker walks in from the beach. And that's kind of structural. Like all measurement, you can't just look at the measurement and know the answer for your service. You've got to interpret the measurement number in the context of your service, but it should be helpful. We hope this is particularly helpful on the sort of time series basis. One of the things that we're always trying to find different ways to show the data, and I'm particularly keen on the spine plots, of which I don't think we've really showing these to their best advantage as some other audits do just yet. But in principle, it's possible to take all the measures and put them on, excuse me, on a single plot, a so-called spine plot. Now, this is these are available on NNAP online, and there's actually quite a good description of those. But it allows you to see everything for your unit and compare to the national average. And so see if you're on the right-hand side, then you're doing well. So this is my own units, for example. And we're very good at deferred cord clamping, a bit better than the regional average. But both the regional average and our unit are better than the national patch, which is this gray bar here. There are other things, BPD being an example, where we're a bit more concerning, certainly below where we'd hope to be on the national average, not as good as the regional average, etc. So that the idea is to try to bring that together into a single plot. I don't know how many people have a unit poster who recognize this. Could we have a little hands up? Does that work in Zoom? Some people nodding. Couple of people, some of the people I can see, about half have got their hands up. So I would like to think that every neonatal unit in the country, and people keep assuring me this is the case, that everyone's got poster A up. Poster 1, poster 2, I think they're called, don't they? So the idea is that this summarizes the data and that it's designed to be parent facing. I think it's probably most useful for professionals, in all honesty. And that poster 2 is about, what have we done about what our data show? So that's the intention of these posters. They certainly have some brand recognition, and they're talked about by other audits. So I hope that they are valuable to you. We welcome feedback about those, about how to make that better. Daniela, do you want to come in?
Can I ask a question, or would you rather me asking in the end?
You can ask now if you like.
Okay. I have 2 questions. Regarding the posters, is the last year's poster already available to access? Because I was not able to find it, and I'm quite new in this neonatal data. And also, in terms of the results, do you have any framework or any guidance for the units to improve their results, or it is up to the units and up to the structure to make and or find solutions to improve these results? What is your recommendation, please?
Fantastic. So the 2021 unit posters are available online for you now. The 2022 data posters are not yet online for you now, because the 2022 analysis is still ongoing.
I got the results from 2021, but not from the 2022. You're right. Yeah.
Yeah. So and this is the kind of the worst time in the year for out-of-date posterness, if you like. There's something else coming that will help with that. In terms of what should you do about having results that show one thing or the other. If you look at the report, either there's a what are we calling it, Rachel? A summary report. It's a 10-page document that's on the NNAP website for each year.
Yeah, that's right.
In amongst that, you'll see we make a key finding. We say rates of deferred cord clamping are improving, for example. We make recommendations, and these are very carefully thought about, and some of them have been on the slides as we've gone through. We think very hard about how to make recommendations, and increasingly come under pressure to do recommendations in particular ways, to make less of them. And that's partly because the NHS is slightly drowning in recommendations, and partly because it's not really okay to make recommendations that are unachievable. And there may be other reasons why we're limited in the recommendations we can make. But one of alongside the recommendations, there are, we hope, links to tools that might help you to improve. So examples would be, there are some British Association of Perinatal Medicine, BAPM, toolkits for quality improvement, for example. So there's one for antenatal optimization, there's one for deferred cord clamping, which annoyingly they call optimal cord clamping. So I hope that there are some resources that we point to, and certainly that's what we in the project team we think we're pointing to. I hope that's helpful.
Can I just add to that, Sam?
Yeah.
So we are our summary report has to be very, very concise, so it's 10 pages. So we do link to those recommendations that are specifically aimed at neonatal services rather than national bodies within that summary report. But there's also an appendix PDF that you can download, and after each chapter, each measure area, there's a section on next steps and useful resources, and that's got all of the recommendations and links to all of those kind of toolkits that Sam mentioned. I think you've just seen, but I've dropped the link to the poster generator in the chat, but that is, as Sam said, just 2021 posters at the moment. But also, if you do have any ideas for other things you'd like to see us produce, do let us know, because it's really useful to know from you what would be helpful.
We're all about facilitating change, really. That's kind of our mission. So I want to keep going, and in fact, there's a slide about the poster generator, with the link on it, but it's in the chat, which might be easier to copy and paste out. So this is our current way of showing you the data, and this will remain a thing for a little while yet. It was ahead of its time. It was. I think it's pretty good. We're going to bring better things into the world because the internet continues to evolve, doesn't it? But there's quite a lot here. You can find quite a lot of things that you might want to find here. And if you need guidance on that, just email us and we'll help you to work your way around through it. What about the future? The future is always different. That's the only constant in the NHS change, isn't it? The system appropriately wants us to publish data in close to real time. So rather than publishing the data once a year, they want us to publish the data as often as is practicable and useful. And so we're going to dissociate that from the annual report. So we'll end up with a system whereby we do produce an annual report, which is 10 pages, state of the nation, and there'll be a longer document alongside that. But the data about, say, your deferred cord clamping will be available to a unit to start with quarterly. And the first phase of that will be going live in early July. So you'll be able to see your an annual average for your last quarter in July. And I'm going to show you an example of that in a minute. One of the challenges around that is a lot of this reporting is going to be public facing. That's a requirement on us. And it will necessarily be data that you've entered quite recently. So it might be a little bit fresh, one might say. And so we're trying to distinguish between data for improvement and data for assurance. So data for improvement is data that you can use for quality improvement. It might not yet be your final version of the data, but it's what it looks like as it's been put in. And data for assurance, where you've had a chance to go back and think, did I really mean that baby's brain injury was classified in this way? And so data for assurance will be on an annual rolling model. And I'm going to show you some examples of this. So I talked about the BAPM Super 7, as we like to call them in Yorkshire, the 7 antenatal optimization interventions that are named in MAP-NEO SIP. It's just gone up to 9, but the key interventions are the same. So things like deferred cord clamping, antenatal steroids, and the like.
Sam, sorry, you just mentioned that it's going up to 9. We've actually had a question and I found the right place to put it in.
Excellent.
Somebody asked whether we're going to be adding those extra 2 in. So before I forget the question, I'm just going to put that in there.
Great. So we're going to think about whether to do that or not. Inside the MAP-NEO, no, sorry, it's not called that. Saving Babies' Lives Care Bundle document. It gives a pretty strong steer that we won't be doing that. But that we didn't write that. We're going to have a think about whether measuring volume guarantee, ventilation, and use of caffeine is necessary, appropriate, etc., and whether it'll add value. And we'll be doing that. So we won't be measuring volume guarantee and caffeine anytime soon. But thank you for raising that. So there's these 7 interventions. One we don't have a measure for, and one we have a measure for in the 2022 data, but not in the 2021 data. And unfortunately, this talk is based on the 2021 data necessarily. But this is the way that our reporting will look, kind of roughly. The colors and other things will be different. So give you a bit of a feel for what we're going to be putting out. So firstly, on the horizontal axis, this is 2017 through to 2023. And you'll be able to change that data by this slider. So you'll be able to focus on just this part of the graph if you chose to. Each diamond, and this is for a particular ODN, is 1 quarter. But it's what the data look. It's called an annual rolling average. I'm sorry, my screen's doing something really annoying again. I just got to make my. And you can see that, and the blue dotted line and the blue diamonds is this, in this case, this network. The green is the national average. And the gray is designed to give you, the middle half of units, the middle half of networks, this is actually middle half of units. And the light gray is the middle 80%. So if we were up here, if this unit was up here, they'd be thinking they were fantastic. And if they were down here, they'd be thinking there might be something they wanted to do about that. The red, very important. You can see there's quite a lot of missing data. And missing data is really important. If you've got a low proportion of missing data, like there is on the right-hand side of this plot, you can be reasonably confident that you're actually measuring something. If there's a higher proportion of missing data, you just can't be that confident. And so I think that's going to be very key as this goes forward. Will we see continued apparent improvements, or will it be leveling off? We hope we'll all be getting better. And then down in the bottom panels, you can see we've broken this by gestations. This particular measure is what proportion of babies get all the interventions. So for a 27-weeker, are they warm? Have they been steroid exposed in the correct interval? Have they had magnesium? Are they delivered in the right place? Did they get early breast milk, etc.? The way that this will work is in layers. What I've just shown you will be layer 2. The first layer will be, we have not developed yet, but the first layer will be, I hope, similar to the unit posters that we showed you a few slides ago. And then layer 3 will look something like this, but it won't just be a composite measure, a measure of a bunch of things together. It will be each individual component. So you'll be able to see the graph for deferred cord clamping and the graph for antisteroids for your unit. We won't put that in the public domain because it runs the risk of identifying patients. There's some important challenges with this. As I say, the data might be a little bit fresh. It will need to be as good as it can be when you put it in the first time, or you'll need data entry review processes that will need to be pretty close to real time in order for it to be useful. And this is relevant because everybody who works in a neonatal unit puts in data that is relevant to the audit. And I've shown you some examples in this of a composite metric, but there'll also be there's a composite outcomes metric, but there'll be public facing reporting of first consultation, for example. So you can see that there's a necessity to get the data entry good. Particular things that I know cause people to trip up is in my unit, the admission time is a particular problem. So we have to clean the admission time very actively, and our ward clocks are good at doing that. We know that the daily data is a thing that we describe, and daily data is often good because it's payment sensitive. The data you nursing colleagues put in affects how your neonatologists get paid. And there are specific medical items that the two most salient examples are about brain injury and about necrotizing enterocolitis, but also bloodstream infection. So there are some real challenges around this, but we hope that the data flowing in close to real time, which is quite challenging for all sorts of reasons, will actually improve the use of the data. So I did say I would say something about the importance of. So this is just some examples taken from a document that you can easily find online, the NNAP Measures Guide. This is how we classify whether babies get BPD. If these fields are filled in, we're all right. And in fact, generally, data completeness for BPD is extremely good. But we've got a thing called the Measures Guide that shows where we take the data from for every field. I mentioned that there's a parent-facing report, and that's I was going to say it's simplified. It is, I guess, simplified, but it's written with the parental reader in mind. And as I say, the posters are designed to be. I'm not going to talk loads about validation. I've touched on that already, so I might leave that to one side, noting the time. But I did want to talk about the national data opt-out. This is a riveting topic of conversation. But you may be aware that if you go to your GP because you've got a chest infection, some GP surgeries will say, "Would you like to opt out of all national data?" And some GP surgeries have a tiny little poster at the bottom of the counter. So GP surgeries vary greatly in their enthusiasm for trying to help people not send their data to national projects. And that's called the National Data Opt-out process. So that does not apply to NNAP. Having said that, the parents whose babies are in your care can choose to opt out of NNAP. And we find they don't want to do that very often, and we don't want to encourage them, to be honest, but they can still do that. And the details of how to do that you can get from us, you can get from our privacy notice. It is kind of clearly a professional responsibility. If somebody says that they've got a problem with data, then we need to explain to them how they can opt out of this thing. But like Embrace and other key things for measuring quality in the NHS. We don't, the national data opt-out process doesn't apply to NNAP. We've got an out from that. Rachel achieved that. So there's the privacy notice, or riveting document. I thoroughly recommend it for bedtime reading. We've got the RCPCH website is good in parts, and the NNAP bit is brilliant. So I commend that to you. NNAP Online is currently where all the data is, and that will hang around for a bit. Certainly in the next months, it will be there. In the long term, we'll end up migrating things. There's only one Sam Oddie, pretty much. So it's IE. So if you want to email me, or indeed email NNAP, and we're relatively easy to find, at least we hope we are. So please do get in touch. That's all good. And it's 7 minutes past 1, so I'm going to get off, and hopefully there'll be some questions or discussion. Deathly silence settles across the internet.
Sam, did you want to stop sharing so that we can see each other?
What an excellent reminder. Thank you.
Okay.
I can see some of you, and I can see more of you now. It's great.
It would be great to hear your questions and comments. I think Sam just shared some really important and stark, but also encouraging data. So it'd be great to hear your thoughts on it, and also your challenges that you're faced with in contributing to that data. I think it's a really good opportunity to kind of feedback to the team, but also ask any questions that you have. So I shall put myself back on mute and give you that opportunity.
So you could put questions in the chat, or you could sing out and unmute yourself and sing out.
So hopefully I've responded to most of the things in the chat, but there are just to say there are a couple of comments around when you talked about neonatal nurse staffing, around raising awareness with nursing students and giving more placements in the field of neonatology. I'm just going to scan, see if there's anything else that I missed.
Fantastic. While you do that, I'll just make a quick point about entering the data for that, if that's okay. In neonatal, units vary in how they put that particular data item in. We've got a pretty clear description of what counts as a nurse. Jamie, our nurse manager, is keen to tell me that it's wrong. And you can imagine that different people have different perspectives about it. But in order for us to be able to usefully make comparisons between units, we have to have a version of the truth. And so there is this description. I think it says something like, what is a nurse? But that's in the measures guide. And so the thing that Jamie was disagreeing with, it excludes one of our, well, it excludes our educated nurses, because it's people who've got a coal face allocated role. And you'll find the definition there. We know that sometimes people, I don't mean about the nurse staffing, but we know that sometimes people put in data that is misleading. And it's a bit like when I was at school, when the chemistry teacher would always say, it's your own time you're wasting, Sam. There's not really any point fiddling the temperature or changing the birth weight. And it's dishonest as well, isn't it? People aren't very often tempted to do that kind of thing, but I'm aware that it's a temptation sometimes. Claire, I think you've got a hand up.
Yeah, so what I was getting at was the fact that the reason why we have got an issue with staffing is that it's from grassroots, in that the staff, so the training now for adults doesn't include anything to do with neonates. They don't have placements here very often in the neonatal field. So therefore they don't know that we exist, and they don't know that we are an option that they could go to after they're qualified. So I recently did a a sort of staff awareness day for recruitment with adult students, and I had 10 people out of the whole day. We were the highest area that had interest to come and work on the neonatal unit. So that's where we're missing the staff. We've come through an era where the training has been divided up into adult training, children's training, psychiatric training, and we've not had exposure, and that's why we've got a staffing problem. So what I want to know is there any sort of help from sort of the RCPC, NNAP, etc., and the Neonatal Nurses Association that could go to the government to sort of get the training to be looked at differently from an adult nurse perspective, so we can get these nurses. That's the problem, and it's the grassroots issue.
So thanks very much for your comment. We were discussing the recommendation that we were going to make around nurse staffing just yesterday, but we'll certainly take your comment into account. Thank you. And there's a comment in the chat from Anne-Marie.
Sorry, Sam, can I just pick up on that as well? I think from our point of view, Claire, we are working, one of our core aims, in fact, is to promote neonatal nursing and to raise its profile and to kind of help neonatal nurses showcase their work in order to kind of raise that profile as well. So we're very much focusing on that side of things. We supported the Be a Neonatal Nurse hashtag, if you've followed that on Twitter. And our new website will have a page that we're hoping will launch in the next 2 weeks or so, or at least in June, that is Be a Neonatal Nurse. And we're hoping phase 2 of that, so it won't be the initial launch, but phase 2 of that will have an interactive neonatal nurse career pathway, so they can click on the different options in terms of career, and they'll either see a recording or text from a neonatal nurse in that role to kind of help promote each of the different avenues nurses can take within neonatal nursing. So I think that's another element people aren't always aware of as well. And the other thing to say there also is that the NNA offers a free membership for all student nurses and student midwives. So that isn't just students in child nursing, it's all nurses, with the hope that we can kind of trigger an interest or show an element of neonatal nursing that maybe haven't been considered or thought about. So we do have a free membership for all student nurses to do help promote that, because then they will see all of our events, our scholarships, our special interest groups, our journal, and all sorts of things, and hopefully kind of engage them in a way that then promotes them to move toward neonates in their career. So it is something we're focusing on, but we're always keen to hear ideas of ways to kind of develop that focus of our work. And we are producing more and more events for our student membership, which has grown considerably in the last year or two. So always open for ideas and discussion around that.
Thanks, Charlotte. So there's a comment in the chat from Anne-Marie Heath about, can ANPs be counted as senior review in the first 24 hours? We have an issue for our transitional care babies. So there's a couple of things to say about that. So nurse practitioners who are acting in a second tier role can count as because if they're acting as a registrar, why wouldn't they be able to offer the appropriate communication to the family? That we're very clear about that, and that's in the definition. And nurse practitioners operating as tier 1 can't be, because there is an expectation from our parents, as we've consulted with them, around speaking to a senior member of the team, that they get a different thing. Clearly, the nurse is going to talk to them when the baby's admitted to the neonatal unit. And finally, transitional care isn't part of that measure, which may not be correct, but there's an apples to apples comparison thing. The reason we're keen to keep that to neonatal units only is so that we're really clear that we're comparing like with like. I think it might come to you in a minute, Daniela, but can I ask Nicola, you've got a question?
Yeah, it was just to touch on the conversation about the nurse staffing. I also work in Yorkshire and Humber, as does Sam. So I know within our region, we've had quite a big drive around trying to get the adult nurses on board, and we've actually done quite extensive recruitment events out through the university to the adult qualified nurses and nurses that are due to qualify, with support from the NNA, where we've kind of advertise the free involvement and the free access to the NNA as well. And actually it's been really, really helpful. I think at our last event we had 131 attendees, and they are then going on to join forces. And we are managing now to get into kind of the training programs as well and start trying to have conversations about restructuring their placement. And I think I sit on the National Educators Board as well, and I know that's a conversation that's happening across the country. So hopefully we will start to see some improvement over time with that. So I just wanted to mention that really.
Fantastic, thank you. Daniela, did you want to ask a question?
Hi, Sam. Yes, in our unit at the moment, we are trying to focus on 3 topics, and one is actually the temperature, because we think it's crucial in neonates to have an accurate temperature from the delivery moment to up to when they go to the unit. And we are trying to come up to solutions to try and improve that. And actually, we have created QI project around it, and it has been helpful. But in terms of improving data, do you have any suggestions, or is anybody doing any work around the temperature? I was just curious.
Yeah, there's a lot of people who've done a lot of work on that. So you'll find some improvement stories on our website, and I think it's I can't name them, but I'm certain, nearly certain, that you'll find some temperature related improvement stories on the website. Rachel's got a thumbs up.
Thank you.
I've invested enormous amounts of other people's time in looking at this issue, and a lot of improvement work's been done at in my own centre. So we got really good at this, and then and we used to go on about how much better we were than our colleagues in Leeds, and colleagues in Leeds are now better than us, which is kind of, I kind of try to take that as flattery.
Because I think for us, what we are finding is it needs to be collaborative work from the nursing and the doctors, because what happens is we document and record the temperature now, because before it was not used to be a process, but now it is. And then the doctors don't change the time of birth on the data. So obviously we have the wrong data, because it looks like the temperature has not been recorded on admission when it actually hasn't has been recorded. So I'll be curious to see the work around other units. So thank you.
So I was going to make a broad, or try and broaden out what you'd said a little bit. I was super encouraged to hear a nursing colleague able to describe one of the top 3, and I imagine you could probably name all of the top 3 improvement priorities for your unit, which is fantastic, because in order to be able to do improvement work, you need to know what the plan is. You need to have a bit of a plan. It doesn't have to be very prescriptive, but there's got to be some prioritization, and that's a challenge. So everybody knowing that what they're going to do. Somebody said of our admission process that everyone knows what's going on all the time, which I was amazed by, because I'd been involved in designing it and I didn't think I did. But the idea that people think there's a plan, know what the plan is really encouraging. So I think that's great. There's definitely some stuff around getting the admission time and getting the birth time and all of that correct. I'm sure that's absolutely right. The easiest thing to do with temperature is to improve the data, and there's a danger that people just kind of improve the admission temperature without actually improving the temperature of the patient, if you see what I mean. So there's it's not about picking the best temperature, it's about making the babies actually normothermic. And there's we need to be careful about just improving that.
Thank you.
Excellent. Great to have questions. Anyone else got a comment or a question? Anne-Marie says she finds the breast milk one frustrating. Yeah, I mean, isn't supporting women to provide breast milk for their babies intrinsically a frustrating process? I absolutely get that. I think that it's probably harder in some places than others. Anne-Marie hasn't said where she works, but there is some objective evidence that breast milk is less. Breast milk use is less prevalent in general in all kinds of babies in the north and west of England, and more prevalent in the south and east. And so that makes it a slightly different hill to climb. But we've all got to care for the patients in front of us, haven't we? So, but it is very difficult. The UNICEF baby friendly stuff, I think, is a really useful tool, and I would commend that. Conflict of interest aside. Very good. Any other comments, questions about how we measure and how we help to or try to support improvement? That's our mission. Cheryl, I think they've had enough of us. I think we'll have to get off while they're still.
I was going to say I agree, but I don't mean it quite as you do. Okay, so I think it's a perfect end. I think we've had a really useful and informative session there. And again, thank you all so much for coming, but thank you also to Sam and to Rachel and also to Lucy for helping to organise this and put it all together and for speaking to us all today. Again, I think, you know, the data and everything is really really fascinating, and Sam, you covered some of the questions that I had around, you know, the data entry process and who's doing it, and whether sometimes people are adding data that isn't necessarily exactly what might be reflecting the actual situation in terms of staffing. But you kind of touched on that, but really, really helpful. Thank you so much for your time.